The Self-Care Learning and Discovery Series is back, and it's bigger and bolder than ever. This is the premier self-care event of the year, bringing together self-care enthusiasts of all backgrounds and disciplines from around the world. The World Health Organization defines self-care as the ability of individuals, families, and communities to promote health, prevent disease, maintain health, and to cope with illness and disability with or without the support of a healthcare provider. We also know that self-care means different things to different people. What does self-care mean to you? You'll have ample opportunity to reflect on this question during the Discovery Series, with more than 20 interactive virtual sessions organized by self-care experts worldwide. The Discovery Series will elevate cutting-edge research, programming, and advocacy insights across a wide variety of self-care topics, and we encourage you to attend as many sessions as possible, especially on topics that may be new to you. The Self-Care Learning and Discovery Series, a core activity of the Self-Care Trailblazer Group, is organized by the White Ribbon Alliance in partnership with co-sponsor organizations and esteemed steering committee members. We also want to thank all our session organizers and presenters who have voluntarily dedicated their time to curate this event with us. We are pleased to share that every session will offer live, simultaneous interpretation in French, Spanish, and English. To access the interpretation, simply navigate to your meeting controls located at the bottom of your screen. Click on the globe icon labeled Interpretation and select the language you'd like to hear. Joining from your phone, tap on the ellipses to find the interpretation feature and then select your language. Please note, you can switch languages at any time throughout the presentation. The session is now about to begin. Don't forget, whether you're working to influence policies or programs, advance universal health coverage, or improve your own self-care, we hope that you will take the learnings from today's discussion and apply it to your own work. To that end, we invite you to continue the conversation and take action with us by becoming a member of the Self-Care Trailblazer Group. So get curious, jump in, and share your ideas and insights with us. We look forward to advancing self-care together.
Yes, good morning, good afternoon, good evening, everyone, from wherever you are tuned in from. And we are really happy that you could join us for this very important and timely conversation on pioneering self-care solutions to drive access to HIV prevention and family planning. My name is Wawira Nyaga, and I work with ABAC, and I shall be co-moderating this session with my esteemed colleagues, Anna Ramu and Michelle Wyland. And introductions will follow shortly. But first things first, in the introduction video, we just had the definition of WHO about self-care and a couple of others from other different people. But we do want to hear from you. What does self-care mean to you in the context of sexual and reproductive health? My colleague will be posting a Mentimeter link. Please click on that. And in one or two words, just tell us, what does self-care mean to you? Thank you. I'm sure we have more than 3 people. Come on. We want to hear from you. Thank you very much. I'm seeing very interesting things: flexibility, autonomy, empowerment, health, body autonomy, flexibility. And even as we continue to post that, I'm going to introduce my colleague, Anna, to give a session overview and introduce the speakers. Over to you, Anna.
Thank you very much, Waira. It's very exciting to see you all here today. It is very exciting to be part of this whole series and seeing how self-care is gaining momentum globally with countries, both in terms of policy and integrating self-care into that, and also through the impressive works that partners are doing on the ground in introducing and scaling interventions. We've been seeing some really impressive examples and really big shifts in the last few years, both in the family planning and SRHR space, as well as diagnostics and more broadly on access to health information and services. So as part of that, on the first part of the session today, we will hear lessons and best practice from 5 live successful self-care interventions in family planning and HIV prevention. And these range from new methods, but also to platforms that facilitate self-care uptake. More specifically, we will hear from George on Path's work on scaling DMPSC and self-injection, from Alexandra on PSI's work on the Kaya diaphragm, from Charlotte on PS Kenya's work on HIV self-testing, from Sarah on Triggerize's TICO self-care platform, and from Kate on AVAC's work on the dual prevention pill. On the second part of the session, we will have a Q&A and an interactive debate section before wrapping up. So please feel free to take a note of your questions to share during the Q&A session, or post your questions in the chat for our 5 presenters to respond to. And with that, I'm going to hand over to George to start taking us through Pat's work on the MPSC.
Thank you very much, Anne, for that introduction. And glad to be here this afternoon trying to discuss this important topic. Basically telling you about the past work on being able to support the scaling up of self-injection and DMPSC globally. Where are we now? Just maybe before we can be able to dive into that, just tell you that the Injectables Access Collaborative Project provides data-driven clinical assistance, coordination, resources, and tools to ensure that the women and girls have increased access to DMPSC and self-injection as part of the expanded range of contraceptive methods. And we work in 11 focus countries and also provide short-term technical assistance in additional countries upon request. Next slide, please. Yes, so as you can see, by the end of year 2022, we had a total number of 56 countries that had both DMPSC and self-injection regulatory approval, and another 17 countries with DMPSC regulatory approval only. Next, please. So still for the same period, you note that, that's next slide, please. No, before that one. Sorry. Okay, thank you. So you can see that at the end of the same period, Q4 2022, we still just had 54 countries offering DMPSC in their respective countries, and a total number of 34 countries were actually able to offering self-injection or poised to offer self-injection in their respective countries. And what we mean by that is that you know that actually these are countries actually which are already providing self-injection. And when we are talking about provision of DMPSC, this is defined as having at least one non-confidential DMPSC order documenting the consensus planning group, or the spreadsheet which usually monitors DMPSC, and self-injection defined as having at least one or non-confidential order documenting CPG, and also being reported as having SI approval. Next, please. So as per through the Q2 of 2023, we observed that over 100,000 providers were trained for safe injection, of which just over 1/4 are community health workers. And over the next year, we expect to see definitely further increases in community health workers, since some of the countries are actually approving some of their policies to be able to have the community health workers program also be able to offer BMPSC and self-injection. So for example, we have Zambia, which has just had their approval for the community health workers. Next, please. Now, if you look at this, when we look at the aggregate DMPSC and self-injection growth, through the quarter, through over time rather, you'll note up to Q2 2023, you actually see a growing trend in self-injection vis as a proportion of DMPSC vis, increasing from as low as 8% in Q1 of 2021 up to 2021 in Q2 2023. This is a substantial growth in self-injection. Now, why it is not reflected in this chart, DMPSC makes up over 1/3 of the total DMPA vis reported to the AC DMPSC in dashboard rather, in Q2 2023. Next, please. Thanks. So, through the 7 years of technical assistance to ministries and partners that we have engaged in introducing and scaling up the self-injection and DMPSC program, the Access Collaborative has accumulated key findings, has also had key insights, and also recommendation for implementing self-injection at scale. So it is from this basis that we formulated a number of recommended, what we can refer to as recommended best practices. And you will note that actually these are 5 that are highlighted here. And it is recommended that if the country is scaling up DMPSC and self-injection, we need to establish clear coordination mechanisms with ministries of health leadership to be able to advance scale up coherently and cohesively. Then the next one, you need also train health workers using on-job approaches to be able to effectively improve outcomes. Now, the third recommended practice is to be able to conduct post-training supportive supervision, which ensures that providers have incorporated new learning at high standards, and also be able to address challenges, all unintended consequences arising out of the new practice and intervention. Now, the fourth recommended practice is also to expand community health workers' provision of family planning to include DMPSC and self-injection, because these live closer to the people, closer to the clients. So it means they are able actually they have a lot of time for them. And again, also they are able to be accessed with ease. Now, the last one, which is the fifth, it says also expand access to DMPSC, including self-injection through private sector delivery channels by training and supporting pharmacy and drug shop staff. So you will note that in most countries, and countries which have pharmacies, and also as far as having some other small drug stores like drug shops, a number of people first actually go to these facilities before they can go actually to facilities maybe in the public sector or the rest. So it means if we expand this, then we are increasing actually access. Next, please. And you can be able to access more of some other insights through our library for DMPSC resources, which is at www.fpoptions.org. Thank you.
Hi, everyone. I think I take it next from here. I'm Alexandra Angel. a technical advisor with Population Services International. I have a little bit of a cold today, so if my voice is a little extra gravelly, I apologize. But I'll be speaking to respond to this question that's up on the screen. Could a new diaphragm fill the market gap in sub-Saharan Africa? Next slide. So first, getting on the same page, what is this new diaphragm? This is the Kaya Contour Diaphragm and Gel. And there are a few key aspects, benefits of it that make it a little bit different from traditional or older models of diaphragms. So first of all, it comes in a single size that fits most women, which means that it's accessible without having to visit a provider. So for more traditional diaphragms, you do have to go into a health center to be fitted through an exam to know which size is right for you. With the Kaya diaphragm, that's not needed. And then it also brings together some 3 different benefits that are kind of uniquely seen in one place, in one contraceptive method in the diaphragm. And that is that it is reusable, that it is on demand, and that it is discreet. And while this method is available in many places in the world, it's not yet widely available in sub-Saharan Africa. Next slide. We, the ECO project funded by USAID, undertook a couple of pilots to introduce this method into two contexts, into Niger and into Benin. These were smaller pilots, so not at scale quite yet. But we did work through a number of different channels or sectors. The method was available in the private sector, where users could access the method for a subsidized price. In Niger, it was also available through public sector centers, where users could access it without having to pay for the method. And then in Niger, it was also accessible via community health workers who were able to discuss the method, counsel on it, and sell it directly to clients door to door or in other places in the community. And that was also at a subsidized price for most of the intervention. Next slide. As part of these couple of pilots, we undertook some research, 2 different studies. And in the following slides, as I talk about some of the learnings, you'll see information that comes from both of these studies. They were very similar. They just came at different points in time. And again, we were looking to answer this question: will Kaya be acceptable and used in Niger and Benin? And to answer that question, our study was mixed methods. So it draws from some quantitative survey responses. And I see that I wrote qualitative survey, that's meant to say quantitative survey. And also with in-depth interviews with adopters, providers, and then also potential male partners of Kaya users. Next slide. So here, taking a look at some of the quantitative results. And first up, I think, one of the things we're most interested in is, will people continue using this method? So both in Niger and in Benin, we did find that among those people surveyed 6 months after adopting the method, an average of 77% of those users shared that they were continuing to use the Kaya diaphragm. Obviously, there are going to be discontinuers with any method. In Niger, interestingly, we found that the top reason cited for discontinuation was not a method-related reason for discontinuing. It wasn't something that users shared they disliked about the method, but rather that they were just looking to fall pregnant, to become pregnant again. We did see that this was addressing some unmet need as well. In particular, in Benin, more than a quarter of those who had adopted Kaya shared that they had not been using a different method, modern method of family planning immediately before adopting Kaya. And then also, interestingly, in Benin, we found that a number of women were using the method alongside some way of tracking their fertility. And 45% of users shared that they chose to use Kaya only during their fertile periods in their cycle. Next slide. Then a couple of little nuggets of insights from our qualitative results. A number of people during in-depth interviews shared that the reason that they were particularly attracted to this method was that it was a non-hormonal option. So this indicated to us that this could be a very good option for those that are wary of modern methods that might cause side effects. We also found that a number of adopters shared that they were using it, that they appreciated because they had infrequent sex, and Kaya as an on-demand method was ideal for them. It allowed them to use the method when they wanted to, when they needed to, when they anticipated having sex, and they could forget about it, not have to think about a particular method during times when they were not anticipating being with a partner. We also found that users shared that it was easy to use during some very early sort of formative interviews and conversations as part of this pilot. There was some initial thoughts that people might have distaste for a method that they had to self-place vaginally and insert themselves. But among adopters, among our in-depth interview participants, we didn't see that reflected in their reflections at all. Next slide. So just a couple of conclusions before I wrap up. We did find that Kaya was well received among users, even in contexts such as Benin and Niger, where FP use is particularly low. Kaya might also serve as an entry point for new users. And women who have sex infrequently may be a key population, may particularly appreciate this as an additional method among their choices. These next 2 points come from a little bit digging more into the research that we conducted, and I didn't have time to sort of touch on them as much in this presentation, but I'll mention them here, and then I'll also drop a link to one of our published pieces of literature where you can read more. As part of our research, we did find that women across different education levels were saying that Kaya was easy to use. And while we didn't conduct research in rural settings, this might indicate that this could be a method that works well for those types of settings. But we acknowledge that more research there would be really interesting to see. And then similar to something that George was saying, we also found that quality counseling available of job aids were highly important when working with the providers or the community health workers that would be distributing or sharing about this method to increase and really bolster the client's understanding and successful use of the self-care method. Next slide, I'll just say thank you and look forward to any questions.
Great, thank you. So I'll take it up from here. My name is Dr. Charlotte Pahe from PS Kenya, and I'll change the pace just a bit. Look at what we've done regarding HIV and just how we've used HIV self-testing kits as an entry point to prevention and SRHFP as well. Next slide. So this will be experiences from our CIF-funded project that ran from November of 2020 and ended last month. And the reason, so we implemented in 2 counties in Kenya, that's Kisumu and Nairobi, and this is because these are 2 of the highest burden counties in the country. However, the project was also implemented in Uganda and Nigeria. We'll be sharing experiences, particularly from Kenya. In Kenya, the HIV prevalence is about 4%. And so we find that as HIV programming is scaling up and coming to saturation, we find that our testing at facility level is yielding fewer and fewer HIV positive individuals. So we thought HIV self-testing kits could particularly give us an entry point where people can test where they are, as opposed to actually having to go to facilities. And in that case, then meeting the person who they should. And this work started actually with a focus particularly on men, whose testing coverage was a bit lower than women. And so we found that we needed to identify some of the challenges to scale up HIV self-testing in the private sector as well. The reason we thought of the private sector was we really wanted a project that is sustainable, given that the donor funding and the donor landscape for HIV particularly is dwindling over time. So what we wanted to do is really increase awareness. So we're asking ourselves how to increase awareness and the demand for HIV self-testing kits. And on the supply side, we really wanted to complement the role of the pharmacist so that they can be able to assist in the usage and next steps as well. And then, of course, for a private pharmacist, for a community pharmacist, the issue would be how does that really help them to grow their overall self-care? So in this particular work, we had identified that a community pharmacist is an accessible point for the public to get them care from there and to really use HIV self-testing as an entry point. So HIV, so the target population for the work was sexually active males and females, 18 to 34 for females, and 35 plus for males. And we really wanted to position HIV self-testing as an entry point for PrEP and other HIV prevention and self-care products. Although eventually we really we did a lot more work with HIV self-testing and other SRH products. Next slide. Great. So this is how the summary, I'll just look at the top part looked like. We wanted to build a self-care insight-driven campaign that's going to feature and position HIV self-testing as part of a larger HIV prevention modality that had PEP inside their PrEP and condoms, as well as SRH, and the U2U, which is the undetectable is equal to untransmittable spectrum of care. And who are really looking at reaching more than 2 million people through various social media platforms. So the idea was really to improve access and uptake of both HIV self-testing kits and HIV prevention and SRH products. I wanted to do this through both pharmacies that were physical and online pharmacies, which we engaged 118 pharmacies in total. We also wanted to improve linkage to HIV prevention, SRH, and confirmatory testing thereafter, and then to just build an ecosystem that is consumer-centered across and to make sure that we're actually reaching the people that we needed to. Next slide. Great. So this was what we hypothesized the project would look like. We really wanted to improve access, like I mentioned, by leveraging insight-driven campaigns in various channels so that our users would actually prefer this particular modality and use it. And so what we wanted to do was to position pharmacies as an option where you can access all these products and services. And so to do that, we needed to build the awareness of HIV self-testing simultaneously and help clients overcome their fear of testing so that they're not worried about a HIV positive result, because the other messaging was really going to be around U2U messaging, but also letting users know where to really access the HIV self-testing kits from. And we also wanted to demonstrate an investment case for self-care products and to demonstrate that pharmacies could really potentially be a self-sustaining service delivery point for the community, where we could train pharmacies as self-care providers that are offering a range of products and services across. Next slide. Great. So this is what we thought would end up being our 5 outcome areas. Since we'll mention them as we go along, we'll skip this part and then we'll mention them one by one. Next slide. So our first one was really around awareness and access to HIV self-testing among the target segments that I've mentioned. So this is one of the basically our message, our campaign was around confirm unajijua. This was developed as a slogan for the overall campaign, meaning confirm, get to know your status. Unajijua in Kenya is a word, it's a Swahili word meaning that you know yourself. So we started to then post this on different social media platforms. And different social media handles. So like this one is Radio Maisha. Radio Maisha is a local, in Kenya, local radio station, which we partnered with to increase awareness for what we were doing for the campaign. And so there's just campaigns that were really matching the different users that we thought and what we profiled and we thought would be available in these particular platforms. So Aska was a WhatsApp chat platform that was developed to particularly ensure that users would then slide into that WhatsApp platform, and if they needed additional support, if they needed linkage to care, if they needed information, then they'd get that, and even information on how to really use the HIV self-testing kit that would be available there. Next slide. So in terms of reach, eventually we did surpass what we intended to do, which was 2 million. We were able to reach way more numbers, more than 6 million by Facebook, more than 5 million by Instagram, more than 1 million by Twitter, over 12,000 by LinkedIn, and over 14,000 by TikTok in terms of those who are able to reach. Next slide. We also undertook community activations. These ones were really us and the project embedding itself within community organized events, whichever the events were. And what we were doing is having demand creation ambassadors who are embedded in this particular community events. The goal was to empower the target audience so that they know what the kit is about, what does it matter, why should I be interested in this? And so this one really took a community-centered approach to make sure that we were reaching everybody who was not otherwise being reached by the pharmacists. So like we're saying here, we leverage community events. Overall, in the country, we reached more than 190,000 people in this particular with this particular method. Yes, we reached actually more than just trying to see, these ones have overlapped here, but we're able to reach more than 76,000 actually. Sorry for that. Across, but this was just particularly through community activations, with more than 50,000 reached in Nairobi and about 20,000 reached in Kisumu County. Next slide. So we also conducted what we call in-store pharmacy activations. These were done during particular period points in time, where we would select particular pharmacies and embed our staff in there, and they would go through supporting the pharmacy in terms of making sure that the branding is visible for HIV self-testing kits, branding is visible for other SRH commodities, and then making sure that as the consumers were coming in to make a purchase, that there was support for them. In total, we managed to activate 96 pharmacies, and we're able to reach more than 170,000 consumers with these particular activities. Next slide. So we also placed some ad-ons within particular media to support demand creation. The idea was to create awareness among the key users with the objective of making sure that we're encouraging uptake of the products. So you can see we're able to play up to more than 87,000. We've had more than 87,000 plays to date. We've reached more than 50,000 through this particular model, and we've been able to. We've had an average play time of about 15.92 Kenya shillings. That's less than $1, and then the average bid for each was about 1 shilling and 50 cents. So really, really affordable. A way of making sure that we're achieving demand creation. Next slide. So in terms of our second output, once we created awareness, we really hoped that would have an increase in uptake. We were able then to really ensure that we were able to mentor retail pharmacies in promoting self-care within the private sector. And what we would do is through this particular campaign in the social media, there would be a link that demonstrates where the consumer, once they come across this message and they're looking at what should I do, there'd be a link that was going to show them where the products were actually available. Next slide. So in terms of cumulative sales, and these were products that were actually being purchased by the particular consumers, we had a target of reaching about 12,000 WHO approved kits being sold. We ended up reaching more than 16,000 WHO pre-qualified HIV self-testing kits being sold. And overall, in terms of the country approved HIV self-testing, we were at more than 16,000, with about 3,000 of some HIV kits being sold. This is data we found in the market, not necessarily WHO pre-qualified kits, but that were still sold in the market. Next slide. So in terms of outcome 3, we wanted to increase the demand and purchase for other self-care products beyond HIV self-testing. We found that with the campaign, one of the products that was which was really preferred among users was condoms, followed by emergency contraceptive pills. We had pregnancy tests being sold as part of the HIV test kit, as well as oral contraceptive, with the lowest product being the lubricants that we were selling. Next slide. So in terms of bundling, the bundle that was most preferred was a HIV self-testing kit as well as a condom. This was followed by the bundle that had a HIV self-testing kit and contraceptive, followed by a HIV-ST kit that was bundled with a pregnancy test, and then lastly, a HIV self-testing kit that was bundled with a lube. So in terms of bundling, which was around our outcome 4, we found that the campaign really helped to combine the sale of HIV self-testing kits together with other SRH products. Next slide. So I missed out on the 5th outcome, which was around linkage, but because that was not the scope of this work, but we'll share that in another forum. So generally, we learned that community activations are really effective in terms of influencing uptake. When we had the embedded demand creation agents, we found that the community was able to reach out to them and ask particular questions in case they were worried about how to use the HIV self-testing kit. And so the demand creation really led to the introduction of other new kits in the market. And actually, overall, the project was also hoping to catalyze the private sector market, so that additional kits would also be sold within the market, and that would lead to the price going down for the HIV self-testing kits overall. Facebook was most preferred, as you saw, for demand creation. And then the WhatsApp chatbot, which was around our 5th outcome area, was preferred because of privacy and confidentiality. And men were actually more likely to engage with the digital counselor, who we called Aska, what you've seen, the synonym around Aska in what our graphics showed. So men actually had a lot more questions. They felt more confident using that platform than any other. We had a frequent review of the chatbot to make sure it was desirable and user-friendly. And then the physical bundling really prompted the consumer to make a purchase decision for more than one product. And that we found that HIV self-testing and the condom, of course, provided dual protection and was the most preferred bundle. Next slide. Great. So we had a lot of lessons along the way, but generally we found that partnerships were our biggest strength. We ended up partnering together with the Ministry of Health through the National AIDS Control Council. We did partner with the regulatory bodies and county governments. The clients and other implementing partners are also key in making sure that we're leveraging off support from each other. We had agencies and distributors who made sure that we had the commodities. And of course, we had the well-meaning pharmacy vendors who really helped us move, because this is product we were not purchasing, as opposed to a previous project where we were actually buying the product for the consumers. So in this particular one, we just managed to move the market just with demand creation only. Next slide. Great. That would be it for our work. Thank you, and I'm ready for any questions.
Hello, everyone. My name is Sarah Malaba. I work at Triggerize, and I'm going to be speaking to you about using the TICO platform, which is a platform owned by Triggerize to connect adolescents and young people to comprehensive sexual and reproductive health services in Africa. Unlike other presenters, I'll take a minute to tell you a little bit about who we are. We are currently known as Triggerize, and shortly you will hear about us being called TICO Africa, aligning our name to the name of our platform. We're a global nonprofit organization headquartered in South Africa, and we use innovative technology, real-time data, and behavioral insights to motivate young people to make positive choices about their health. Through our digital platform, which we call TICO, and our local ecosystem of partners, we connect members who become TICO members to existing providers to meet their health and wellness needs. Since our inception in 2014, we have reached about 2.2 million young people across 6 countries in Africa. So in terms of our intervention profile, we provide sexual and reproductive health services to within all of our operating geographies. And we provide these services, and indeed all the rest of the services, through the public facilities, private clinics, and also pharmacies. We are big on choice, and we want young people to choose when, where, and how to access their SRH and other services. We also provide HIV services, mental health, and youth and employability and entrepreneurship services. So I'll speak a little bit about how it all comes together using the TICO platform. We not only have the TICO platform, which is an app, but also take what we call a platform model to the way that we support young people to access SRH products and services. So once a young person becomes a TICO member, through demand generation that would involve community-based organization, social media, and the mobilizer, they then get access to a network of clinics and pharmacies that include also public facilities where they will be able to access their services. So they get to have choice using the platform approach. And the platform then helps us to connect both the demand side and the supply side in order to give these end users access to the services that they need. And through the funding that we have, then we issue rewards and payments to all the actors on the platform, ensuring that underserved end users actually are able to access the services that they require. So I'll speak to you a little bit about how the adolescent and young person gets onto TICO. So through demand generation that will involve a community-based organization and a community mobilizer, or sometimes a health promoter or a community health worker, an adolescent is able to be signed up to be a TICO member. And they could also be signed up on their own through a self-enrollment, or there could be a peer-to-peer enrollment and referral. Once they're signed up, they would either receive a QR-coded card if they are not on phone. And once they sign up on SMS or WhatsApp, then their membership is through the phone, and you could say they have a digital card. Once they sign up as a TICO member, the membership then allows them to choose where and when and how to access a multitude of services depending on the country, the geography where we're operating, and the services that are available through a network of pre-qualified public and private sector clinics and pharmacies. These facilities use the TICO platform to be able to verify services that they have provided to those young people, which then enables us to receive real-time data around who has received what service where and when. Once the young person has received their service, they will be able to rate the services that they have received, especially if they're on phone, if they have an SMS, if they have a feature phone or a smartphone, they will be able to rate their services. And so those ratings are actually part and parcel of ensuring that we can continue to have young people's voices to ensure accountability around the quality of service they received. So both the private facilities and the pharmacies then get to be fully reimbursed for the services that they have provided to this young person once the verification process has happened. And then the young person is also able to be incentivized, and they get rewarded in terms of miles or TICO points, as we call them, which they will be able to spend on in terms of redeeming at any retail shop that is also TICO affiliated. And then we continue to support the young person along their journey of healthy decision-making through a series of nudges that remind them about their appointments and their follow-ups. Next slide, please. So in summary, since January to end of October, what we have seen so far through our platform is that we have been able to reach slightly above 300,000 users through the TICO platform, and those users have been able to access slightly more than 500,000 services. And when we take a breakdown of the service, thinking about the short-term contraceptives, those are around 250,000 contraceptive services have been taken up within this period, and slightly above 100,000 long-term contraceptive services as well. You can see in terms of HIV testing that we have already provided more than 119,000 HIV testing services, and you see the rest of the services that we have been able to provide up until now. Next. So I'll conclude by talking about, what can we take away in terms of the platform-based approach, and what that mean in terms of providing SRH services to adolescents and young people. One, the TICO platform allows the young people to easily enroll, and this is a critical factor because we want to make their journey of enrollment seamless. They can either enroll themselves through the mobilizer or through referrals from other peers. In terms of building the ecosystem approach, it is important and has been important for us to be able to onboard carefully selected and trained facilities who can provide youth-friendly and stigma-free services. And we continue to monitor this. And once in a while, there would be a suspension based on what we see on the data or the feedback that the young people provide to enable course correction and ensure that these facilities continue to provide youth-friendly services. Users' voice and on-service feedback is critical. And so there is a provision for users to rate the services and a possibility that they could also call a call center in case they have feedback around the service quality that they received. And once also we see a low rating for service delivery, then we also follow up to find out exactly what the user's experience was. The use of nudges is critical, and we continue to be iterative around our nudges so as to enable the young people to start and continue their journey to good sexual reproductive health. The use of real-time data that we are able to receive from the platform helps us to quickly look into enrollment pathways, understand the method mix, the continuation and discontinuation rates, as well as repeat use, among others. And we are able to do this on real-time basis, and so be able to quickly adapt and course correct as required. Thank you, and I hope to hear more questions around TICO.
Thank you, Sarah, and all of the presenters that have gone so far. I will be rounding out the 5 presentations. My name is Kate Siegel. I am a Senior Program Manager with the Product Introduction and Access team at AVAC, and today I will be talking about the dual prevention pill and how we are preparing the market for the first MPT with PrEP. So the current HIV prevention pipeline, as you can see, is diverse, with many delivery forms and drug formulations in development. There are a number of HIV prevention tools that are already currently available. 2 new options, the dapivirine vaginal ring and injectable cabotegravir for PrEP, have been approved in several countries and are being introduced in implementation science projects. Aside from these, most products in the pipeline are in very early stages of development. There are only 2 new products that could potentially be rolled out in the next couple of years. Oral PrEP was first approved in 2012, though rollout and scale-up was slow and fragmented for years. In fact, we actually missed the global target in 2020 of reaching 3 million PrEP initiations. That said, since 2020, we have seen rapid scale-up of oral PrEP initiations, and as of mid-2023, there were nearly 5 million cumulative global initiations, with the majority of uptake in sub-Saharan Africa. So multi-purpose prevention technologies, or MPTs, are products designed to address more than one SRH need. There are 24 MPTs currently in development, but similar to the HIV prevention pipeline, the majority are in very early stages. The DPP, however, is the closest MPT to market, and if approved, it would be the first MPT available since the internal condom. Importantly, as I mentioned, it would be the first MPT with PrEP. Therefore, the DPP would lay the foundation for future MPTs in the pipeline, and as you can see at the bottom of the chart, there are currently 2 MPTs in development. 2 DPPs, excuse me. So let's talk a little bit more about what the DPP is as a product. It is a daily oral pill that combines oral PrEP with a combined oral contraceptive to prevent HIV and pregnancy at the same time. It has a 28-day regimen, with the first 21 days being combined PrEP and OC pills, followed by 7 days of PrEP-only pills to allow for monthly bleeding, which you can see on the top right image. The different pink and peach colors were preferred by end users to differentiate the 2 different types of pills in the pack. The packaging, as you can see on the bottom right, will be a cold form blister in a wallet pack. This is meant to more closely resemble oral contraceptive pill packs and to differentiate DPP packaging from the pill bottles that are associated with oral PrEP and ARVs. Users will be able to actually tear off weekly sheets to enable ease of use. Now, what I'm describing are attributes of what we're calling the first generation DPP, which is being developed by the pharmaceutical company Viatris. This DPP could receive regulatory approval in 2025, which means that it could be ready for rollout in the next couple of years. There is also a second DPP in development. Population Council and Medicines 360 are developing a DPP with FTAF as the oral PrEP component. The difference with this DPP is that it could be 1/3 smaller than the first generation DPP, though we are still waiting for FTAF to be approved for use in cisgender women, and so it would not be able to be rolled out until that approval is in place. So there is a coalition of organizations called the DPP Consortium that is working to bring the DPP to market, and I will just share a few highlights from our work. So on the product development front, we've learned that women want MPTs that are discreet, easy to use, and resemble contraception to the extent possible to minimize stigma associated with PrEP and ARVs. The DPP pill colors and packaging were validated with end users to reflect their input in product design. We also learned that the DPP will follow a different development pathway than many other new products. So because the DPP combines 2 previously approved products, oral PrEP and oral contraception, the usual clinical trial process is actually not required. Instead, the DPP must undergo bioequivalence testing, which measures whether the absorption rate of the DPP in the body is roughly equal to when you take up oral PrEP and oral contraceptive pills separately, but at the same time. This should accelerate time to market and approval, as BE or bioequivalence studies are much shorter than clinical trials. Learnings from DPP market research can also help reframe HIV prevention around self-care and preparation for the future. So we found through this market research that women often struggle to balance societal expectations, relationship dynamics, and personal desires and motivations. So they often begin using oral contraception or PrEP after negative triggers, and usually in response to the actions of their romantic partners. So you can see examples of the creative route that we developed for the DPP at the bottom based on these findings. And users really resonated with messaging that celebrated their individuality, and they saw the DPP as a tool that could help them to prepare for life's unpredictability. Male partners liked being positioned as in it together with their female partners, and they also viewed themselves as protectors of women in their lives. So these showed us some opportunities to potentially engage men on supporting DPP use for their partners. Campaigns on the DPP can expand beyond the product itself to focus on broader SRH and gender issues. And in terms of delivery platforms, so the DPP will leverage channels that make access more convenient and align with user preferences, such as pharmacies and telehealth, like we've heard from our previous presenters. Because the DPP is a contraceptive MPT, it could also catalyze differentiating and demedicalizing PrEP delivery, which will improve integration of HIV prevention and SRH services. The CHI and NYU actually conducted cost effectiveness modeling for the DPP and found that the DPP could be cost effective, particularly in settings with HIV incidence among certain populations, and importantly, when it increases adherence. So effective counseling and policy changes to authorize PrEP in new channels will be critical to improving delivery platforms for the DPP and will also benefit future MPTs. So just to round us out, how does the DPP support self-care? It is a user-controlled MPT that affords women agency to mediate use, which is often hard to negotiate with condoms, the only other MPT currently available. There is an option for users to disguise the DPP as contraception around those who might be resistant to PrEP use, such as romantic partners. And lastly, one pill instead of two separate products makes the DPP more convenient, which could help motivate uptake, adherence, and continued use, which we have seen are challenges with oral PrEP and oral contraception separately. So if you'd like to learn more, I know this was a very quick overview, but there are opportunities to hear more about the DPP if you're interested. If you'll be at ICASA, we do have a whole satellite session dedicated to the DPP on December 4th. We would love for you to attend. We also have a dedicated page on PrEP Watch that is chock full of resources. And you can feel free to reach out to me at kate@avac.org. And thank you to our consortium partners and funders. And thank you.
And thank you so much to all our speakers for such incredible presentations. And what a better way to end the presentations other than hearing from, directly from the beneficiaries and of some of the two featured solutions. In the first video, we're going to be hearing from two women that have been using the Kaya diaphragm, and they'll be telling us about what motivated them to use the diaphragm and their experience so far. And in the second video, we're going to be hearing from one of the users of the TICO platform. So please play the video. Thank you.
Je ne vis pas avec mon homme pour le moment. Donc il vient par moment. Donc quand il vient et que je suis dans ma période d'ovulation, j'utilise le diaphragme Kaya pour éviter les grossesses pour le moment.
J'utilise la méthode Kaya quand mon mari revient de son voyage. Donc, c'est par moment. On n'utilise pas tous les jours. Et j'utilise aussi ça pour éviter les grossesses non désirées.
C'est économique, c'est pas coûteux et c'est très simple à utiliser. Ça ne donne pas de stress, ça ne donne pas de peur de dire ah, est-ce que le préservatif n'a pas eu de soucis, est-ce que j'ai pris mes pilules, tout ça, tu n'auras pas à compter les pelles. Non, tu es à l'aise, tu es tranquille.
J'étais réticente sur les autres méthodes, mais celle-ci, elle est pratique et elle est facile à utiliser. C'est une méthode très facile, c'est discret. Au début, on peut être craintif, mais quand tu auras à l'utiliser une fois, deux fois, tu vas comprendre que c'est pratique, qu'on peut le faire facilement. C'est plus pratique et c'est sans inconvénient selon moi.
Thank you very much. The next video is from a Tico user, and apologies, part of it is in Swahili. So if you understand Swahili, please help the other people by translating on the comments.
Wacheni na show Tico why. Tico is an ecosystem na pia membership platform. Once ukishenda hapo unaweza kumeka na appointment. Na ukimeka na appointment unaweza kutumia your Tico number na utapata services for free. Tico iko partnered with clinics and pharmacy across Kenya. Mali unaweza kuenda ku access free services. Unaweza kupata contraceptive, mental health, HIV na pia many more health services. Na hivi karibuni kutakuwa na job training from centers za mtaa. Watu wangu, na hivyo ndo mimi maanisha nikisema do more with Tico. What are you waiting for?
Tenda zaidi na Tico.
Well, thanks everybody for these exciting presentations. I found them very interesting myself, and it was very interesting to hear from users directly that have actually initiated using some of these methods and platforms. I would like to open the floor to questions for the 5 excellent presenters. And I can see also some questions flowing in through the chat, so I'll start sharing those as well if I don't have any questions yet from the floor. Cool. Maybe I can make a quick start from some of the questions that are here. So a couple of questions from Kimberly. A question to Alexandra. Are you able to say what is next for the Kaya diaphragm in the countries where you did the pilot, and more broadly to test Kaya in new places as well?
Yeah, I can share a couple updates. So the project that did fund the pilots has closed at this point. So, and the mandate under that project was to generate evidence around the acceptability of Kaya. So that is sort of as far as the project went through closing. We did have conversations around including getting Kaya into the USAID Global Supply Chain catalog. And it's not there yet. I think we have hopes that those conversations will continue. We've also spoken with other projects and funders sort of implementing in those same countries where the pilots took place to see what opportunities in the future could continue pilots in different contexts within those countries, or could take the work another step further in terms of scale. In Niger, I can say that they did, I believe last year, and I think this year, had plans to include Kaya in the MOH's discussions around forecasting and what opportunities there might be through the public sector to continue making Kaya more available. And I think those are the updates. I will say, you know, we continue, those of us that worked on this project and who have had exposure to Kaya, I think are always very eager to continue the conversation and continue sharing the work and the evidence that was generated. So if there are opportunities to continue doing that with anyone on that call, I'd be more than happy to connect. So I suppose one other update is that I do believe that in Nigeria, Kaya is available through the private sector. It's outside of the work that we did through this particular project, but another important piece of information to share. Thank you for that question.
Thank you, Alexandra. Thanks for the question, Kimberly. Next question is for Sarah around the TICO platform, and it's around what processes or procedures are in place for data security and confidentiality. And then also it's an open question to all the other interventions that have platforms involved. Over to you, Sarah.
Yeah, thank you very much. So in speaking to this question, I need to answer the question also around what kind of data do we collect at enrollment. And at enrollment, we only collect 2 data points: your date of birth and your gender. So we do not collect names of young people. Usually on our platform, we work with adolescents and young people from the age of 15. So you could imagine that those don't even have national identification cards. And then because we are trying to also provide stigma-free services, we only collect their date of birth and their gender. The young people who consent to a phone enrollment, they are the ones that share with us inadvertently an SMS message. So they have to send a word to an SMS to an SMS line where they get then enrolled onto the TICO platform. So we do not ask them to give us their phone numbers. All the young people who then provide us with an SMS or enroll through an SMS are required to consent for any follow-up calls. And those who decline to get any calls from us then do not receive any calls or messages from us as well. Then thinking about just the data of the young people, because we work with the network of providers, the client data in as far as service delivery is concerned is with the clinicians in the clinics. And those are submitted to consent rules and data confidentiality in as far as the clinician and user relationship is concerned. On the platform, we do not collect data such as status, okay? When it comes to aspects such as SRH, the providers are only able to verify that this unique number of young person received this type of contraception. So our data is indeed de-identified, and we do not sell data to anyone. So our data privacy requirements follow the country data privacy and confidentiality requirements that have been put in place. And we have also, a data protection officer who ensures that we continue to ensure compliance. All the data that is posted through our website is de-identified and in form of aggregate numbers, even though through our dashboard, we'll be able to drill down to particular geographies and facilities to understand where and how the young people receive the services that they received. Thank you.
Thank you so much, Sarah. Let me scan through the chat. I think that there was a question from me actually for Charlotte on the SHIPS program. I'm just curious to hear, how did that bundling of products work from a pricing perspective, and were there any incentive structures in place for specific bundles, or was that up to the private providers to decide?
Great. Thank you, Anna. So yes, that was actually up to the private provider. So we've had 2 different projects around HIV self-testing. With the first one, also funded by CIF, we had price reduction. So there we could influence price at that point. But with the second one, we were trying to see how do we make it sustainable. We were not able to propose a price because we lost the subsidy that came with the previous project. So what we did, we let the provider determine what that bundle would be and what the price point would be. but what we provided for them as a value add is the driving of traffic to their stores. And then we also provided them with branded merchandise so that anytime a consumer would find themselves there, they'd know that, yes, I'm talking to the right provider because this provider is actually linked to the information that I've seen in the different social media platforms. Thank you.
Thanks so much, Charlotte. Are there any other questions from the group? Feel free to unmute yourselves and share with the rest of us. Well, I have a couple more. I can jump in here. I can keep going for a long time. Self-care is a beginner's domain. So I have a question around, a question to Kate on the DPP. So I think this is a very interesting one. I think it's considering how it's going to be the first MPT in the market after a very, very long time. I'm just wondering what needs to happen to integrate DPP into HIV and family planning programs, considering how separate these two areas have been in the past, and any sort of key pillars this introduction should focus on.
Yeah, thank you, Anna, for your question. A lot needs to happen to catalyze integration of systems and services. As you noted, integration is something that the field has been talking about for a really long time, but operationalizing integration, has been somewhat of a challenge and somewhat slower. We've seen it, in certain projects, but sort of at scale, it hasn't been fully realized yet. And so there are a few different levels that we are working at to try to integrate services and systems. We think provider training is going to be really important. One hypothesis about the DPP is that FP providers will be critical to reaching new DPP users, but family planning providers do not always deliver PrEP, often do not deliver PrEP, and so provider training is going to be a really critical aspect in order to roll out the DPP. So training FP providers on PrEP provision, ensuring that HIV providers can also offer family planning, and then more up the chain, ensuring that procurement systems, supply chain systems, funders, there needs to be a real integration sort of up the chain. So it is quite a big task that will have to happen in order to deliver this product. We have seen interest from both HIV and family planning stakeholders in the DPP. It will likely sort of be delivered through traditional HIV sort of channels, given that the oral PrEP component is more expensive than the oral contraceptive component. But we are doing a lot of thinking around how to innovate how silos currently function, whether it's integrating M&E systems, procurement processes, and trying to have as many of those conversations as possible in advance of the DPP being approved.
Right, that's exciting. Thank you so much, Kate. And in the interest of time, I think I'll hand this over to my colleague Waira to take us through a couple of provocative questions that can give us a little bit of thinking for the future. And please feel free to reach out to any of our speakers with any questions you might have after this session.
Hey, thank you very much, Anna, and thank you everyone, the presenters and those that asked questions. And like Anna said, because you're still welcome to share more questions, but we want to turn over the tables and we want to hear what you think about this, evolving space. And the first thing we want to do is, get your temperature about how you feel about some of these things. And so I need you to go to your phone or your laptop and using, you could either agree with us or disagree using emojis. And so for a smiley, it means that you strongly agree, and for a means that you disagree, and you could also be neutral. So the first question is going to be, and because there are very, very many, there are many things going on and different feelings about self-care. So do you agree or disagree whether that an increase in self-care solutions may potentially mean shifting the burden of healthcare from the system to the individual? Do you agree? Do you disagree? Or you're not sure? Post that on the chat, and we'll see what people are thinking. Or you could even react. Oh, agree. Okay. Other people? Right. And while we think about that, I think something to ponder about, is that a good thing or a bad thing? Because we could look at it. Does it mean totally shifting to the individual and then it starts becoming burdensome? Or is it a shift in a nice way? So a question for another day. So next question. So there have been concerns around, the quality of care when, increasingly use self-care solutions. So do you agree or disagree that self-care solutions may lead to a compromise in the quality of care? What do you feel about that? There should be a conditional option. And Eva, I'll invite you to come off mute and maybe share what you think about that.
Hello, all. What I mean by a conditional option is that in terms of mental health and also the already existing conceptions or beliefs about statuses and such, especially when you're talking about HIV statuses and reproductive health, having the care and self-care option means that it moves from being a situation where you have a third party in the room to help you or to walk you through the process of making decisions, whether to use protection, whether to go on additional care if you're positive, whether to use family planning or reproductive health options. And it brings that back to now the couple, in case it's being done, in the context of a couple. If it's individual, I don't think it would compromise the quality of care, but then it's in a context of a couple. You have two people with probably differing conceptions about these kinds of things, reproductive health, sexual health. And that means that without a third party there to kind of ease you down the route to finding best options for you, and also depending on the kind of relationship the pair has, you can find that it might, negatively impact it. But again, with education, of course, this is mitigated greatly. But then, yeah, in the context of like a couple reproductive health, I think maybe there's some chance for compromise. Otherwise, if it is just for the person, especially if it is for the woman because she understands what's going on and what the impacts of everything is, then she's she has more power to make a right decision because she has a lot more at stake, I think. And I know I am biased, but that's what I meant. Yes, thank you.
Thank you so much, Eva, for your thoughts that are greatly appreciated. And the last one, I see a lot of people are non-committal about the issue about quality. The last one, I promise. So the benefits of self-care solutions outweigh potential harms. What do you feel about that? So I see a lot of agreement. So next, we want to move into also getting your feel about what you think about what we should be prioritizing when we think about, self-care. So there's an option of developing more solutions, self-care solutions, and the more the merrier, right? And we could also focus on, resources on generating evidence on self-care and also addressing the current gaps. We could also think that what needs to be prioritized is creating demand and addressing other, socio-cultural issues that have been affecting the uptake of some of those solutions. Or we could think about increasing access to tools that could support adoption and sustained use of the available self-care tools. So according to you, if you were to rank these priorities, which one would you put first? Please go to the Mentimeter. And Junkie, if you could help us see how the conversation is going. I am not able to tell how many people have voted. Wow. Interesting the way things are moving. Okay. I will imagine we have most of the votes in, and the majority, wow, we have a tie. So, oh, okay. I'll give it a few more minutes. Interesting. All right. So it looks like a lot of people, if you still have your vote, please, yes, please. All right. All right. I think we're almost there. So according to the polls that we have right now, it looks like a lot of people feel that we should prioritize creating demand of the current self-care solutions, followed by ensuring that we have access to those tools that can support, adoption and sustained use. And at the last bit, that's when we should think about creating more solutions. So I would like to invite anyone that voted for demand generation, all increasing access to tools, to come off mute and share with us their thoughts as to why we should be prioritizing that. Anyone, somebody.
I'm happy to kick us off. I think what's interesting about these two is that, as we've seen from this session, there are clearly a range of self-care options that are currently available, but perhaps access is not as widespread for some. As we've seen with Kaya, and I think a lot of us argue the DPP, they might be a bit more niche products that, particular users would prefer, but maybe they don't know about them, or access is quite limited to particular delivery channels or particular settings. And so I think to the extent that we can generate demand as well as increase access to available tools, because they might be the right option for a particular person, I think that more investment could be put in those areas.
Thank you very much, Kate. Somebody else who was not on the panel. Thank you, Kate. Okay. It looks like, all right. Anyone else? Any other thoughts in terms of what we should be putting into consideration or what we should be prioritizing in self-care solutions? All right.
Well, where I could go, sorry. So
yes, please.
Yeah, because so the disclaimer, of course, is that I was in the panel, but I am in agreement with Kate. And just looking at the different solutions, of course, they're so recent. We've not really gotten to have them really get to saturation yet. the counties or the regions where we worked at, those are the few who are aware about what we did. And yet potentially with everybody's presentation, we really were able to reach people who would have never reached any other way. So I think I'm in agreement with Kate that why there's a feeling that we could need a bit more demand creation is, of course, then we still need to saturate what we've already done. And even that then will give us evidence and a case for why additional products and services should be available through self-care. Thank you. Yeah.
Thank you so much, Fahe. Other thoughts before we move to the next? Okay, one last thing. Our last Mentimeter, question is, I do know, and we appreciate that we are saying we can, put, the development or the thinking, it's not a priority to start thinking about new technologies, but when you look at what is available and what has been presented, what are some of the examples of self-care practices or technologies have the potential to revolutionize sexual and reproductive health access and outcomes? I know that's a very broad question. It might be biased, but then what are some of those examples? What should we be thinking about? Are we missing something? Please, if you can go to the Mentimeter and type your response. We have this open for another 30 seconds. So we have the self-injection. The HIV self-testing. Oh, interesting, self-test for STIs, especially now that we are seeing those ones on the rise. Use of digital platforms, applications for direct consumer options, merging new technologies. Wow. I have seen a new one I haven't had before, functional medicine. What's that? If you type that, are you able to share with us your thoughts as we wrap up?
Hey, Vera, it's me, Janki. I actually wrote functional medicine, and the reason why is because I think there are a lot of practices in functional medicine that center the person, and I think as women, we might know what it feels like to not have our physician really listen or understand what we're going through, and to have a platform or a medical practice that brings all of these great technologies together, and gives women the empowered option to not only consult their physician, but to also, know what is going on in their bodies and to take empowered decisions with their physicians rather than under the guidance of their physicians, I think is something that functional medicine really helps with.
Thank you very much, Janki. And thank you everyone for being very active audience. And I'm going to hand it over to Mitchell Warren to wrap us up. Welcome, Mitchell.
Great. Well, Vera, thank you so much. And I want to thank all of the panel and all of the participants. This has been such a thrilling session, so full. And I hope you can hear me. I'm actually on the streets of New York, and we all make choices and need to make the best of our situations. But really want to thank you all, and really just to close by talking about how wonderful the session was in tying together something we talk a lot about at AVAC. And for those who don't know, I'm Mitchell Warren. I direct AVAC, And I'm so grateful to Wawira and Anna for pulling this together, and Kate for your leadership in this, and putting together a panel that really highlighted something that at AVAC we think a lot about. How do you translate options into choices? And when you think about the last 90 minutes, from a self-injection to a new diaphragm, to a dual prevention pill, those are the biomedical options. HIV self-testing too. Those are the biomedical options that research and development provides us. And that is incredibly exciting. And that is something we all want more of. And we also want to make sure that that is very user-centered. To Janki, your last point, it's not just how do we deliver those technologies, but how do we develop them with users involved from the very beginning. And we certainly saw that with self-injection, with the Kaya diaphragm that was very much about responding to what users wanted. The dual prevention pill responding to what women talk about, wanting a single product that can meet multiple reproductive health needs. This is so exciting and so important. But, and I really was so excited to have Trigger Eyes on the panel, because if we don't deliver those options and make those actual choices for individuals, all of that great science is meaningless. It was once said that a safe and effective vaccine that sits on a shelf is neither safe nor effective. It's true of any one of these products. As great as they are, if we can't deliver them, if we can't empower individuals to really understand and want those products, and to demand a self-care approach, then all the R&D in the world is exciting science that gets published. It doesn't have impact. So how do we translate these options into choices? Most of all, we listen to the individual. We listen to the user. What does she want? And I would say, what does he want? Or what do they want at different points in their lives? From where? And I think, again, you saw that with Kaya. Where do you want to get it? From whom do you want to get it? How do you want to talk about these things? That is self-care. And this session really did a beautiful job of providing so many real life examples of how we develop products, or need to develop products, with users involved from the beginning, and how we need to deliver them in programs and with policies, with providers, with peer support, so that self-care actually is a reality, that those biomedical options become choices that fit into people's lives. And that was made so clear by the entire panel, and by Wawira and Anna, by how you framed this from the very beginning. So I want to thank you all. Self-care is a journey that we're all on, and we need to accelerate that journey to impact. And I think we have great seeds of that just on the last 90 minutes. So I look forward to working with all of you across sexual reproductive health communities in integrating them all, and again, making those options choices. Thanks so much, and really thank you so much for the Self-Care Consortium for pulling this entire couple of weeks together. And we look forward to working with you all going forward.
Thank you, Mitchell. And thank you everyone for making the time, and let's continue having this conversation.
Thanks, everybody.
Bye.
Cheers,
Thanks,
all.
everybody. Bye.
Thank you, everyone.
Thank you. Thank you.
You all.